So, hello everyone, good afternoon and welcome. We are today meeting for an opportunity for two of our on-campus experts to provide you with some information about the current state of the pandemic as well as the future state of the pandemic. Before we move into that, we really just wanted to acknowledge all of the hard work that everyone on campus has done really to work together to keep the campus safe. We've had a great opportunity for during our reentry testing, as well as our vaccination rates and our booster rates. And we're really moving in a positive direction, and we couldn't have done all of that without all of you. So we do have today Dr. Marianne Sullivan, and who has played a critical role in helping us through all of our COVID efforts, and as well as Dr. Erin Bromage, who is an on-campus expert, but is also very well known nationwide and beyond. So we're very fortunate to have them with us today. So to begin today's discussion, we have some questions that have been submitted, but we also have the opportunity for all of you to submit questions in the chat. So if you would like to do that, please feel free to do so. And we will begin with Dr. Bromage. Thank you.
Thanks, Deb. So thank you for being here, and actually thank you for the university allowing us to address the campus directly so that we can talk a little bit more about what is going on in the campus, but what is sort of going on nationwide. So I'm glad we are doing this. So what I would like to do is just give just a quick breakdown of where we are, both nationally, but more importantly, state and locally, in regards to the pandemic. It's just really for those of you that are not following the data as closely as what I am. So if we go into the next slide. So Massachusetts-wide, no surprise here, we've come off an absolutely massive surge of Omicron cases over the last 8 weeks, seeing highs that we've never seen before, approaching 5-10 times the highest number of cases that we have observed in the past. The great part of this is we're back down to cases below where we were just prior to Thanksgiving, and the trajectory is continuing to head down. The important part is the state has finally got testing under control. We're now seeing that much fewer of the tests being run are coming back positive. When we start seeing testing go up, as in the percent positivity going up, it means we're not doing enough testing. We're not capturing as many of the cases in the population as we should. This is flattened and dropping lately, so that is great. The other good news, which is a big metric that we should be looking at in sort of the state where we are now, is the hospitalizations and deaths. The number of cases that we have is not as good an indicator as what happens once you have an infection. And so we did see quite a dramatic surge in hospitalizations, and that is both with and because of COVID. But COVID did put a very significant strain on the hospitals once again, that was exacerbated by the the loss of beds that we haven't been able to staff at the moment because of fewer medical people. But the great thing is, about a week and a half, 2 weeks ago, that turned. Hospitalizations are coming down. One of the key metrics that I've been following is ER wait times. It got up to nearly 14 hours in early mid-January was the average wait time in an ER, and it's dropping down. It's now down to about 5 hours, where the pre-surge average was around about 3 hours or so. So there's still a little bit of pressure coming from the infections that are out there, but we're seeing both ER and hospitalizations decreasing. One of the other good pieces of news is the average hospitalization stay has gone from 4.8 days to roughly 2 days, which is again a great metric on severity, that while we've had so many infections that led to so many hospitalizations, on average they were less severe. Massachusetts has done really well. There was analysis that came out today, really well in the context of deaths, which is not great, but Massachusetts is in the lowest 5 in the country in regards to how we have dealt with mortality since April of 2020. So when we had really no idea what was going on at the beginning of the pandemic, it was a bit of a mess. We got hit early. But when we look at how well the policies and the society has protected our citizenry, we can see that it's really Hawaii, Connecticut, New Hampshire, and Massachusetts that have really led the way. Next slide. So one of the really important metrics that we've been looking at is this passive surveillance, this wastewater testing. And why this is good is it doesn't matter how many people are testing on a given day. It's just, let's look at how much COVID, how much RNA of this virus is actually present in the wastewater. And so it is blind to the number of people that are testing, and it is just telling you how much viral material is being released into the wastewater. So this gives us about a week advance notice of what is going on in regards to cases. We will see this peak about a week before we see the peak in the community. We'll see it drop faster than we see the drop in cases in the community. So we saw around about the middle of January that it hit its peak at an astronomical level, 10 times higher than we had ever seen before. Even with last winter, there was just so many people infected. But then the plummet started. A week later, we saw cases peak and start to drop. And the really great thing in the piece that I've been looking at is making sure that we're not going to hit a shoulder or a rebound. That was something that I was really worried about, and I'm still looking at to make sure that the little sister of Omicron, so the BA.2, is not going to cause a sustained shoulder in regards to infection. So far, the trajectory has been really good and going down. Again, we are below Thanksgiving level numbers and still heading down. We will expect, because conditions are still fairly good for transmission, being cold, being indoors, and with a lot of mobility that we still have in community, we will expect this to stay elevated, but it looks like it's only going to be at roughly 5%-ish of the massive peak that we saw, and should be something similar to, if you look at the middle of that chart, if you look at that low plateau that we had through February, March, and into April, it should be similar to that, if not a little bit lower. Next one. So no surprise, Omicron is just a beast. The orange color here was Delta, the variant that was really giving us a hard time in regards to both infections but hospitalizations. It was certainly more severe. In came Omicron. Omicron, when it infected an unvaccinated person, was only about 13% to 15% less virulent, less severe than, say, Delta. But in a vaccinated person, it was in the 90%, as in it was only about 10% of the severity that we'd seen in the past. So we got really lucky here. I know that sounds silly with the number of infections that we had, but we did get lucky that it was more infectious, but less virulent. And so we are now at the stage, and I've never seen confidence intervals like this before with any viral variants. Omicron now accounts for 99.9% of all cases in the entire country right now. And they're giving that 0.1% to Delta, but it really is, so low at this stage that our threat is Omicron, which is great because immunity that's come from infection may actually lead to a longer term protection for these people from even Omicron's little sister. Next one. So let's relate this a little bit further to home. I mean, we've seen that our own surveillance on campus, we had about 6% positivity rate with the testing in. That was not surprising at all. When we were coming back to campus, there was a lot of infections in the community. We definitely have seen that both statewide, but also campuses across Massachusetts. If we look here, the 13.21% is the local community. The 7.13% is just the average of all testing. The 13 is without higher education. The 1.8% is what we're seeing in general in higher education institutes, and we're even lower than that, and Marianne will address that. The campus community in general has done remarkably well A big part of that is due to the policies that we have on campus, but it also is an individual decision that we have a very highly vaccinated and a very high rate of boosting in amongst our population that has shown to be the most robust that we can be in preventing infections. So, looking at all the campuses, it's 1.8%. I believe I saw us at 0.6% for our campus for the most recent week. So we are doing very well there. Next one. And this is something I don't think a lot of people have looked at. And this is sort of a bigger picture side of things, is this is surveillance serology. So it is biased to start off with because this is sampling of 135,000 blood donors, the blood that they gave. So it's biased towards people that will donate blood. But that being said, it's then blinded in regards to who it's come from. And what we are seeing is that, US-wide, greater than 16, we're about 68% vaccinated, which is absolutely terrible, but that's where we are. But when we look at the blood of those people and look at, do they actually have antibodies against the virus? And we're just looking at spike protein here, and that could come from vaccination or prior infection. When we look at that, a roughly 94% of the population, the entire US population above the age of 16 from this blood sampling has been exposed to the virus. If we look down the bottom here, it's like 96% for people over 65, 93% for those 16 to 29. Now, that still does leave about 6% of the population that are unvaccinated and uninfected. But this was also November data, and we know what's happened in December and January. So we would look at the seroprevalence, how many people are left in this country who have not yet been exposed to any of the variants or to the vaccine. We would expect this to be higher now, given just how many people were infected with Omicron over the past 2 months. So we are approaching a spot, and it's not endemicity, it's not any of those things, it's not herd immunity. All of those things are, herd immunity is just not possible with this pathogen. Waning immunity, reservoirs in animals, continual change of the virus. Herd immunity doesn't exist. It is now, we have to manage both infection, but the outcomes of infection. And so we've got to work out a way that society actually moves forward, because COVID-0 will never happen. But where we are, we're hitting that stage that almost everybody in the country has been exposed to either the virus or the vaccine, which we know leads to much, much better outcomes from infection. With drugs, with other treatments that come through, we are now hitting that place of, and it's not learn to live with, I want to beat this virus with a, down to a pulp, but there is going to have to be a change now of where we are, because we've got all of these tools in place. We've got to see that, how society actually balances that, knowing that the vast majority of people have been exposed already. And I think that that's where I left this. Is that anything after that? So with that, I will hand off to Marianne to give more of a status of where we are.
Great, thank you, Erin. One thing that I just want to start off with, because I always think it's good to look in the rearview mirror. And I want to go back to February. In February 1st, when we all got that notification that we had our first case of COVID in the state of Massachusetts. And this was an international student, a 20-year-old international student who had come from Wuhan, China, and had tested positive. And that was our first case. And at that time, which was February 1st, there were only 8 cases in the United States, concentrated in California, 1 in Illinois, 1 in Arizona, 1 in Washington. And then in mid-February is when we began to see some travelers who came from Italy back to Rhode Island and Mass, who also tested positive. Then we had the Biogen conference meeting up in Boston, which was February 26th and 27th. And that super spreader event has been shown to be genomically sequenced and related to almost 300,000 cases worldwide. So from that one event, it's been linked to 300,000 cases. On March the 1st, I gave with my colleagues from the College of Nursing an informational session to the entire campus just on what this new virus and this new novel coronavirus was. And we entertained questions and what we knew about it at that point in time. And this slide was actually from that presentation because that was the current status at the time based upon the information from Johns Hopkins and their dashboard. On March the 6th, there was a student who returned from travel abroad in Italy, followed by students who were returning from travel abroad in UK, Ireland, and Madrid. And the gates then opened because then we began to see multiple transmission of cases, primarily driven by global travel throughout the Commonwealth. Next slide, please. Fast forward to yesterday's dashboard, and you can see where we've gone from the low number of cases back in February 27th of 2020 to today's. But one thing that I want to point out is look at the total vaccination doses that have been administered worldwide. Certainly not to the level that we should be at. And we could have a whole discussion on inequality and distribution of vaccines. But the number of vaccines and the vaccine fully dosed individuals is truly remarkable and says a lot to do with our scientific community coming together globally to make this vaccination possible. So when we experienced the Omicron surge, which we first began to notice somewhere around December 18th, and it peaked very, very quickly. So if you recall, that was right about we were ending our semester, right when exams were getting ready to finish. And next slide, please. This is a duplicate of a slide that Erin had already administered. But from the wastewater data, you can see how quickly the peak occurred and just as quickly how it descended. And that's exactly what we saw. Throughout the course of winter session, many individuals tested positive, members of our campus community, faculty, staff, and especially students. And we began to think about how we were going to conduct reentry testing and what we were going to do. And we decided that we were going to do rapid antigen testing because anybody who may have tested positive over winter session would still probably remain positive on a PCR if we used PCR testing. So the decision was made to do rapid antigen testing on reentry. And so we began that the week of January the 2nd, first with faculty, staff, and any students who might be present already on campus. It was a tremendous effort. There were over 56 volunteers from employees across campus who helped to staff the testing center, in addition to 33 contracted employees. And we're so grateful for everyone coming forward and coming together to make that happen. As Erin mentioned, the positivity rates that we saw that first week were certainly much higher than the second week and then certainly higher than the third week. But what we saw was this precipitous drop as we move forward week to week with our testing here on reentry. We tested over 4,100 individuals on reentry, and the cumulative positive rate over those 3 weeks was 6.8. The last week of testing was only 4.6 positivity. So just as rapidly as we saw that Omicron peak rise, we saw it fall, and our data certainly supports that. In fact, in the US, cases have fallen 36% over the last 2 weeks alone. So you can see that the downward trajectory is certainly continuing. And if we could just have the next slide, please. Again, data obtained from the DPH website and duplicating some of what Erin has already showed you. But what I want to focus on too is that this particular dashboard can zero in on our county specific and being Bristol County. So Bristol County, as of January 31st, the rates of positive cases have fallen to about 1,069. That has paralleled weekly downward trajectory from both New Bedford as well as Dartmouth. And so that all bodes well to us in terms of moving forward. I think it goes without saying that vaccination is proven our best defense against this virus. We have antivirals that have been developed that will certainly help. Monoclonal antibody therapy was not shown to be very effective against Omicron variant. So that was stalled in terms of administering for those individuals hospitalized with Omicron. But continued antiviral development, continued vaccination and boostering is really what's going to push us and continue to keep us forward. Two things of note, both Pfizer marketed as Comirnaty, and this week Moderna, marketed as Spikevax, have received full FDA approval. So they are no longer for emergency use authorization only. And just this week, Pfizer has submitted an application to the FDA for approval for vaccination of individuals 6 months to 5 years of age. So that will certainly also help move us forward. At this point, I'm going to turn it back to you, Deb, because I think there's probably some questions that may have been generated.
Thank you, Marianne, and thank you both for that great presentation. I do see that we have some questions coming through. There's actually one in the chat now. Erin, I think this question is for you. The graph on passive surveillance wastewater, is this UMass Massachusetts?
No, so that is Massachusetts-wide, the southern region, so it's around Boston. But as of this morning, I believe if you go to the UMass Dartmouth COVID dashboard, we actually have the wastewater surveillance up there now that covers Citadel. It covers, then we have another collection point that does the entire campus and the law school. And what we're seeing from that is very clear that early January, the very few people that we had here, there was a high level of infection that was around, and then it's dropped down to much lower levels in the past 2 weeks. Keep in mind, this is a person who has been infected and recovered will continue to release RNA, viral RNA from their body in their saliva, in their sweat, in their cells, in their pee, in their poo for potentially 30 to 60 days. So what we're looking for with that data is not a trend where it comes down and just flatlines. That does not necessarily suggest that there is infections in the background. It's a sum of everybody that's been infected over the last 6 weeks, what they're still releasing. A concerning trend for campus, and what we need to look for is what was shown with the wastewater data in Massachusetts, where we start seeing the trend going up. That will be a point that we are watching very carefully, that if that trend starts to come up, that means that we have either more people on campus, or we have a cluster growing on campus, either through infections from the community or inside type of transmission. So it's something that we have been keeping an eye on for the last month. And the trends are important. We're looking for upward trends, which would suggest that there is a growing release of virus on campus, which could suggest more people infected. So keep an eye on that. And then there's a follow-on. Is your opinion wastewater surveillance the best way to monitor? Not picking on the campus. I've been banging for this since over a year. that I've wanted the wastewater treatment, and I'm so happy we've been able to work out a way to do it. One of the limitations that we had was we needed a way to be able to get hold of the material. So we needed central collection points, and it took a while to work out from a 50-year-old buildings where to actually go and where to look, as well as incorporate the law school into it. And I know through no insignificant effort, it took a lot of effort to find a person or a company to actually do this for us and get it up and running. I agree, it is one of the best ways for us to move forward, because what we can do is we can monitor that. And then if we see that rising, we can then deploy resources on campus to isolate where that is. So this is a really great passive surveillance that doesn't require people to buy into testing and come down to testing and staff and do that. But Marianne's team, as well as people that we've got contracted, if we started to see a surge, we have the ability to be able to mobilize resources to then put in surveillance testing of individuals to work out what's going on. So I am so glad we are doing this.
Great, thank you, Erin. I have another question for you. Is there a difference in the level of transmissibility of the virus between vaccinated individuals and unvaccinated individuals? And specifically, do the vaccinated, it's not ended. Specifically, do the vaccinated and unvaccinated, it's not, there's nothing left.
Yeah, so that's always been a question. We know that there is a difference in who gets infected, and it can be anywhere from about a 5-fold difference in vaccinated and unvaccinated. So if I am infected and I've got a group of unvaccinated people and a group of vaccinated people around me, there will be a difference in the number of people that get infected in each of those groups. Some of the vaccinated will get infected, some of the unvaccinated will get infected. And we see roughly, about a 4 to 5-fold difference with just people with 2 shots, and about a 40-fold difference with people with 3 shots after that first week after that. So we know there's a big difference in infection and the ability to get infected to start off with. If you've had J&J and you're 3-4 months out, your ability to resist is very limited. So at first there is a difficulty in getting infected, but once you do get infected, is there a difference? So the answer of that is yes, but marginally. I would treat a person who is infected the same, no matter their vaccination status. We know that they get to the same viral load, which is how much virus material I can collect from a sampling. They hit the same levels there. The only true difference that we're seeing is the clearance rate of the virus is faster in vaccinated individuals. So rather than taking 7, 8, 9 days for it to be at a level that is non-infectious, that happens with unvaccinated people, we are seeing more people at the 5 and 6 days in the vaccinated group. So if the difference really in transmissibility is the quickness of clearing, it cuts about 2 days off, which would make a difference. But in regards to how we treat them anywhere in any public health measure, infected, I don't care about your vaccination status. You are potentially a risk to other people for transmitting and should be treated that way.
Okay, thank you. Marianne, have pediatric vaccines aged 5 through 12 years been fully approved by the FDA?
The answer to that is no. The official approvals for full authorization are only for ages 16 and above at the current time.
Okay.
They're collecting more data, and hopefully we'll get to that point.
Okay, great. Thank you. Another one for you, Marianne. Can you please speak on the amount of time of quarantine and isolation when a positive or a close contact?
Sure. I'll be happy to go over that. The guidance just changed recently in early January. So an individual who is infected or test positive with COVID is subject to a strict isolation period of 5 days. And strict isolation is just that, isolated at home, not amongst family members, but isolating themselves. That 5-day period can then be followed by going out with a full mask, medical grade, preferably 2 to 3 layer medical grade mask, but not participating in any high-risk communal activities, such as dining in a restaurant or dining in our dining halls here on campus, or singing, and a dental procedure where you'd have to remove your mask. So fully masked at all times for an additional 5 days. There are different requirements. That's for the general population. There are different requirements for healthcare providers and other congregate living facilities, et cetera, but I won't go into that. Just so that everybody knows, strict isolation for 5 days, then as long as you're fever-free without fever-reducing medicine and your symptoms have improved, if you were indeed symptomatic, you can return to general mingling with the general population, but fully masked for those next 5 days. Quarantine is a little bit different, and it really does depend upon your vaccination status and whether or not you're fully up to date, which is what the CDC is referring to as someone who is boosted at the time that they are eligible. So if you are fully up to date with your COVID vaccinations and you are exposed or deemed a close contact of someone who has tested positive, you are not subject to quarantine. If, however, you develop symptoms, you must immediately isolate. If you are not fully up to date, you must quarantine. And then it is suggested that you test on day 5 to make sure that that you have not converted and tested positive due to that exposure.
Okay, great. Thank you. Erin, can you address why a false positive on a PCR would occur?
Yeah, so they do occur, and they can occur for a number of reasons. So in order to get a positive, you have to have the RNA there. There has to be a template to amplify it. So it just, qPCR has to have the template. If you don't have it there, it won't. So where did that template come from? You know, if you've got a positive result and then you test a few days later and you don't have it. So there's a couple of things that need to be clear about. So there can be errors, it can be biology, and it can be, you know, straight up mistakes. So an error, it can be at the sampling site. So when you are taking the sample originally, if the person before you had an infection and the person did not change gloves that was doing the swabbing, or you had somebody in your house that was infected and you went and tested yourself, but you had the virus on your hands and you got it onto the swab, it can be introduced there into the medium that we use for testing. And that leads to a positive result. It really was there, but it wasn't infected, like it wasn't part of your infection that we had. That is unusual, especially in a quality testing environment where it's set up properly to look after the air, good protocols in regards to exchange of gloves and PPE and those things. The most common form of false positives comes from the actual procedure inside the lab where they are extracting the RNA from your sample. They are loading it onto a plate and putting it into a machine. When there are very, very few cases in the community, a plate that they load up, so like think of a deck of cards, and on that deck of cards is about 380 individual wells, which means there's 380 individual samples on that plate. If there is, out of that 380, 50 of them are positive, there is a chance that through contamination, a little bit of a positive well spills over into your well, seeds it, and again, we get a positive result. But if we are sampling when there is very low numbers of people that are infected, then those false positives don't come up. So what we get is, unfortunately, during a surge, we end up with more false positives because there's more positives on the plate. And it gets frustrating. And in all the other countries that I'm working, when you get a positive, you go back and test that same sample again to make sure that it's real. But here with the surge and the numbers that we had and the constraints on testing, it's positive and you're thrown into that bin of being infected. So there are good testing centers and there's bad, like the Broad that we've used has been fantastic, but there still will be those side of things. There is then the biology. A lot of people go in for testing very late in their infection cycle because they get told about somebody they were in contact with a week ago, or they're just doing passive surveillance. We could have caught you right on the end of that infection curve. There is a number that comes out, but they don't give that to you. So you might have had a positive, but it took 33 amplifications of your sample in order to get that positive. They give you the result 3 or 4 days later. You go, that doesn't seem right. I don't feel sick. You go back and get another sample taken. And by that stage, you've dropped to 38 and they're counting as a negative. So you could have cleared it. So there are a number of reasons that can both be error on the front end with sampling. Usually a problem at the lab is the one for me that I come across the most commonly, but then it could also be biology, as well. It is, for me, important though, if you get a positive result and you're symptomatic, you are infected. It's as simple as that. If you are symptomatic and get a negative result, treat yourself as infected. It can only amplify a signal if the virus gets onto the swab. And if the swab was not perfect, they didn't get to the zone where the virus is, they're not going to get a positive. So just be truly mindful of symptoms, and a negative is not necessarily, right now, is not necessarily not COVID. In a month or 2 months' time, symptoms when COVID is low, it could be something else. It could be a cold and those type of things. But false positives come around. They're the bane of my existence with the amount of testing that I do, not on me, but in the groups that I work with. But just take 2 pieces of evidence together as being the determining. You had close contact with an infected person, you've tested positive, you're positive. You've had symptoms and a positive result, you're positive. It would only be somebody that had locked themselves away, that really had no contact, got a positive just through sampling, and I had no symptoms. Would I maybe question it? But I would still reduce my activities until I got a second result later that cleared me of the first one.
Okay, great. Thank you so much. Marianne, can you get COVID again within the 3-month period that you may test positive?
Yes, it is possible to be reinfected, and we certainly did see that between the Delta and the Omicron surges. We saw a significant number of individuals who may have been infected with Delta, who then tested positive when Omicron came around, albeit lower pathogenicity, lower clinical disease, but yes, it is possible to get reinfected. So even though, the guidelines are don't retest on a PCR for up to 90 days after your infection, if you do develop symptoms, especially after an exposure, you should isolate, you should retest and reach out to your healthcare provider.
Yeah, and just to add a little bit to that, Delta to Omicron, absolutely. We were seeing reinfections in the 90-day window. I've dealt with about, 1,500 positive cases in the last 6 weeks. And I've got my first out of the 1,500 of being reinfected 4 weeks later. So it can happen, but it's very rare that it does happen. So it's exactly what Marianne said. If you become symptomatic again, you should be, testing. Antigen tests work wonderful with that, just to see what is actually going on. But I would think that for the majority of people who are vaccinated and infected with Omicron, the durability of that protection while Omicron is dominant is going to be very protective for you.
Okay, thank you. Erin, what are your thoughts about swabbing the throat?
Yeah, so Omicron's a bear, and I am having a really difficult time with Omicron in the way that it's as reliably detected as what we found with Delta and Alpha, the ones that came before it. When I'm running testing campaigns, say in the United Kingdom, it is just very common practice to swab your tonsils and then swab your nose as part of the process. And, I've got kids doing that. It's an easy process, and it's been very, very reliable on picking it up. We are seeing people that will be nose positive, throat positive, both positive. And that's why I sort of come back to testing is important, and it really is an important tool, but it's not the only one. If you are sick and you are testing negative, it could be in the back of your throat where we didn't swab. It could be in your nose where we didn't swab. So for me, when I'm testing for my own surveillance of myself and my family, we do throat and nose and put that together. But given that all the tests that are approved in the United States are for the nose, and we know that there are compounds in the throat, there are compounds in your food that you eat that could interfere with the tests, I would stick to how they are approved to be run in order to do the correct test. But again, symptoms and a negative, wait for symptoms to resolve, test again later. I think all the tests that we've been given, the ones that we gave out, come in a 2-pack for a reason. If they come, the first one is positive, there's no need to test, especially if you've got symptoms. But if you have symptoms and get a negative test, the 2-pack is there, wait 36, wait 48 hours, and then test again. That is why they were approved that way. And even if it was in the throat, within a day or two, it will move up to the cells in your nose, and that's where it can actually be picked up. And again, keep in mind, we are trying to pick up free virus and cells being released, viral particles being released from your cells. So it does need to be a good swab. It does need to agitate the nose in order to get a good result.
And if I could just add, we've seen that play out in a lot of households or in a lot of situations where an individual is known to be in close contact, tests negative on, say, day 3 of their exposure, but then within another 24 to 48 hours does test positive. So that repeat testing is really important.
Great, thank you both. Marianne, what is being done to address the impact of long COVID? Has there been any success with managing or treating the syndrome?
So there's still a lot of research being done on long COVID and why certain people are susceptible to it. We really don't have any good answers right now. I think just like other viral diseases that cause this huge inflammatory cytokine response, some people are more predisposed to the long-term effects of that than others, but we don't have a good answer as to why. And we don't really have a good answer as to, how long it will last in certain individuals. So unfortunately, we don't have the data to answer that.
Okay.
Can I add just a bit to that? Because Marianne's completely right, but really good data out of Israel. Vaccination significantly reduces the chances of developing long COVID in people who get infected. So it's once you're infected, what are the chances of developing long COVID? And there is a stark difference between vaccinated and unvaccinated with Omicron out of this study of nearly 70,000 people. So, again, I'm preaching to the choir here, but part of the choir is you go out into the community and interact with each other, people that are not here. And long COVID is one of the things that holds me back from just saying, okay, let's get on with life, because that is, potentially some serious things that affect quality of life for a long period of time. But the reduction in long COVID in fully vaccinated people is quite stark.
Okay, Marianne, will we continue to need COVID-19 vaccines in the future? And this could be either of you, but we'll start with Marianne.
So my personal opinion is yes. I think that we will see reformulations and additional vaccinations as we move forward. But your guess is as good as mine. But that's just my opinion based upon where we're going and what we've seen thus far. Erin, I'll defer to you.
Yeah, there definitely will be reformulations of it. So we've got the Omicron one going through a phase 3 trial right now. Unfortunately, it's going to come after the surge. And that's the problem with, not a problem. We've got to do safety first. We've got to make sure it works. Influenza, we can go from identifying a variant to having a vaccine produced in 90 days because the techniques are really well developed and we can get them through. It takes longer with this one because we don't have the history and the safety data to go with it. So unfortunately, we're always going to be chasing something that's already affected us. Now, there are quite a few new vaccines that are coming out, and some of those are pan-specific against all of the beta coronaviruses that are out there. So that may be possible to have a vaccine that covers multiple variants in the one vaccine. We are still away from it, but I can promise you there will be boosters at the end of this year for people in the highly vulnerable groups. At a minimum, we will see that they will be recommended for those people over the age of 50 or 65. It may be an Omicron booster. It may be something else by that stage. It will be recommended to other people, but I think we will find that this will be incorporated into the annual respiratory virus vaccine side of things, that you might head in for a shot. You 4 variants of influenza and 2 variants of coronavirus, and that's what you get in October of each year to try to blunt the severity of what will be, the winter surge that rolls through.
Okay, thank you. Erin, the next one's for you. I have heard that work is ongoing on a vaccine that would be generally effective versus coronaviruses. Do you know the status of this work?
Yeah, so that's Dr. Howitt's work down in, I think it's Children's Hospital of Texas or something. That was the one that I was just talking about. We've got a similar program going at the moment for influenza. Rather than updating influenza every year and going after the changing stalk, the head of it, we're going after the stalk. And so what we have to identify with coronaviruses is, are there areas of the virus that are evolutionary conserved, that don't change over time? Maybe the virus has to have this particular shape there in order for it to infect cells or replicate or come out of cells. And if we can target a vaccine that goes against something that they can't change, because if they change it, they die out or become less effective. If we can target that, then we might be able to cover all of them, which would be a very rosy outcome, but many of them. So it's still coming. It will be years away, unfortunately, because the urgency of the situation is what led to the speed of these vaccines rolling out, the first ones. Now that the situation may seem urgent in regards to cases, but it's going to be diminishing in regards to urgency of sickness as time goes on. So it will take longer to get approval, because you've got to meet a higher bar of safety. You've got to meet a higher bar of durability and efficacy in order to get them through the approval process.
Okay, great. Thank you. Marianne, how long should we continue to wear masks in public?
So I know this is a question that everybody's wondering about. And, clearly this is the height of our respiratory viral season. And if we can just stay the course a little bit longer, maybe another month or two, I think then we can take a look at rolling back on our mask mandate indoors. But for those that are vulnerable or who have an immunocompromised immune system, they may be masking for a significant longer period of time because the risk is just too great. But for those individuals who are healthy, up to date with their vaccinations, we may be able to go without masks within, the next month or two. That's what I'm hoping.
Yeah,
all right, so
I would echo that as well. Yeah, I would echo that as well. It's not the right time right now, but out of any place that can and should be able to do it, it would be our campus community. We have all bought into collective health. We have all bought into vaccination as being a big part of that. The infection rate of our campus community is very, very low, and it's not reflective of the wider community. Our classrooms have been audited and looked after in regards to ventilation and filtration. So if you've got very little infection on the campus and we've dealt with the physical environment in which we work, I think that we could potentially be a leader in how do we come to a new balance with it here on campus. It doesn't mean that it may not come back on again sometime in the future, but we are and this is part of the pandemic emergency response. We are talking about this. What I have been really pushing for is not to talk about this when the data is there, because we know how slowly things move. We need to be talking about it now so that when the data reflects that this is the right and appropriate move, that the risk of transmission is low enough that the benefits of unmasking in a classroom, for example, outweigh that in regards to cognition and learning and those type of things, that we are ready to move on that at that time. There may be circumstances, labs where you're walking around and on top of each other, they may stay for longer. In the nursing school where they're actually working in high risk environments and coming back, they may stay longer in those areas. But we are definitely discussing this. And I echo Marianne that it's not time now, but I am really hoping that around our spring break, maybe a little bit before it, we have both the external data, the internal data to be able to move to something where on campus, we are looking much better.
Okay, great, thank you. And, the PERT committee continues to meet and, those recommendations will be made and no decision has been made yet, but we will, continue to do that. And we're all looking forward to the place when we don't have to wear masks. But we'll get there, we will get there. So Erin, is there currently a new variant besides Omicron? And what are your thoughts on the stealth variant?
Yeah, so the stealth variant is the wrong name for it. So we were able to identify that there was something new happening from Delta, something new happening because in many of the other countries around the world, we use a TAC path assay, which targets 3 different genes of the virus. And what was happening is, like, when we were doing Delta, you would get a positive off the N, a positive off the S gene, and a positive off the open reading frame. And so you were certain that the person was infected. And then along came some unusual results. Your N target and your open reading frame was positive, but the S was negative. And that was like eye-opening because that's what Alpha did. It was like, was Alpha back or is this something new? And that's what led South Africa to actually start sequencing this and identify that there is a new variant, Omicron, that has this S gene target failure. Basically, the variant deleted a few parts of its genome that we targeted with the test, and you got a negative on that and a positive on the others. And that allowed us to actually trace the prevalence of it throughout the world by using that target failure type test. So the stealth variant is still Omicron. It's just Omicron that has regained or kept that deletion. And so now it comes up S, N, and open reading frame positive. It's not like it's evading our tests. It's just now back to all 3 genes testing positive. So it's just as easy to detect. It now is just difficult from a PCR to differentiate it between, is it Delta or is it the daughter, the sister of Omicron? And the only way we can get at that is then by sequencing some of those samples. And that data that I showed you at the very beginning of the talk is all sequencing data. We've got a positive, it's got S gene target failure or not, send it off to the lab, let's run sequencing of it. Okay, it's Omicron, either BA1 or BA2. There is a BA3, which is a hybrid of BA1 and BA2, but that's where we are. Now, is there a new variant on the horizon? Really, Omicron's got the world. It's got the world by, the throat, and nothing else is going to outcompete it at the moment. The most likely situation is the next variant that emerges will be a great-great-great-grandchild of Omicron. And it will come out. Like, if we give viruses the opportunity to replicate, vaccinated, unvaccinated, it doesn't matter, an opportunity to replicate, we give it an opportunity to mutate and to find something that is advantageous for it. So expect a new variant, but for now, while Omicron is just so infectious, it's going to be BA1, it's going to run out of hosts. BA2 is more infectious. It's going to find the ones that we didn't get and go through. And then there will be another one that comes after that, but hopefully long after that, and we get a reprieve for a while.
And if I could just add to that, Massachusetts is really benefiting by the fact that the Broad Institute is here, and they are genomically sequencing many of the positive results that they process through their lab. So I think the Department of Public Health quoted that at least 30 to 35% of the positives are being sequenced through Broad, which is really, really high across the United States. So we're certainly in a position within the Commonwealth to pick up those variants as they develop.
Okay, so we're coming on 3 o'clock.
Yeah,
Oh.
pointed out that infection with BA1 should lead to very good protection against BA2. And the estimates at this stage of the unvaccinated population in both New York and Massachusetts, roughly 35% of people have already been, of unvaccinated people have already been infected with Omicron. So there's still quite a few bodies left there to get. And that's the shoulder that I was talking about. But there's nothing on the horizon now that is the next scariant that will come along. It's just dealing with Omicron.
Okay, so to close our program today, I want to ask you both, what does the new normal look like over the next few months or years? And will we see a continuous cycle of surges and downtrends?
I'll have a stab at that one first. So my opinion has changed a lot over the last year of what is safe. There are still people that are holding on, and this is fine, it's individual, that says safe is not getting infected. And they will do everything that they possibly can, behaviorally, mask use, limiting contact, doing those type of things. And there will always be those people that safe for them is just not getting infected. My own side of things, given the good health in my family, the age of my family, my children, and all of us being boosted, safe for me is protecting us from actually ending up in hospitalization and something worse. Safe for us is not necessarily avoiding infection. Safe for us is if we do get infected, we know that we have tilted everything in our favor to make sure that's there, that we're going to have good outcomes from it. And I realize not everyone is as privileged as I to be that way. But what we're going to find is that there's going to be this shift of what people perceive as safe. And we're seeing it already with Omicron because people are sort of saying it doesn't seem as bad. So I think that in the next couple of months, as the risk in the community comes down, we are going to find more of a press in regards to, should we still be doing X right now, given where we are? And there's going to be some people holding on to, yes, we have to do everything we can to drive it down to zero. There'll be others that say, actually, this is the live with right now. And there's others saying that we should have done that 2 years ago. So I think we're going to find everything through spring and summer looks much more normal. But we do have to prepare for the fact that viruses don't necessarily evolve to be less pathogenic. It's a random. It could get worse, like it could get better. There is going to be this dance that we do with the virus for a very long time, that there may be a time where we have to do more or do what we're doing now in order to control what's happening. And then there should be times where we're just back to the way it was. It is going to be this ebb and flow for a while, but normalcy in regards to living with, not normal as in 2019, but normalcy in regards to adjusting, live, move, do our things that we normally do, I think we're going to see emerge in March and April of this year and continue through. Marianne?
Yeah, I would agree with that. I think that, there's also been the other side of this pandemic that we haven't even addressed today. And that's the whole mental health crisis and issue that has resulted from the isolation and lack of socialization that this pandemic has brought to us over the last 2 years. And so those individuals who feel comfortable enough, who feel that they are up to date with their vaccines, have low health risks, will begin to re-socialize at a much faster pace than those who may have some underlying health issues that they need to be more conservative with. But I do think that we definitely need to be prepared that this will never reach zero infection state for this particular virus. It will always be with us, and that we just need to be able to address and respond to it appropriately.
Okay, so thank you everyone for the great questions this afternoon, and thank you to Marianne and Erin for enlightening all of us. And stay safe, everyone.